Hi everyone, I hope this is recording, and I'm going to spend the next, I'm hoping about 20 minutes talking about fluid and electrolytes, and in particular just keeping it really simple. How do we focus on understanding the balance of fluid and electrolytes in the human body, and what does it mean for nursing? I'm going to talk a little bit later in another lecture more specifically about electrolytes, but this is just an overview. Okay. So just the bottom line, intake and output should be roughly equal, right? So just roughly equal. And so we're looking at how do we take fluids into our body and how do we excrete fluids. So fluid loss through our skin is a significant amount. It's actually 600 mils a day, and we do that through perspiration. And we do that when we notice it. So we notice we get all hot and sweaty, but we're always excreting some fluid, some small amounts of fluid. So 600 mils through our skin, 400 mils through our lungs, and we see that when we breathe out on a cold day and you see that mist. That's because you've got that hydrated, warmed and hydrated air coming out of your lungs. 1,500 mils for our kidneys, and that note underneath where it says 1 mil per minute is that we ideally are looking to see about 1 mil per minute of urine. So typically we're looking for that. And then about 100 mils from our intestines. So the products of digestion lead us to create stool, and within that stool there's about 100 mil loss of fluid in a 24-hour period. And how do we take it in? Mostly, not surprisingly, from PO liquids, about 1,500 mils. From solid foods, another 800 mils. So we think of solids that have fluid within them, so an apple or vegetables or other even processed foods, so liquid within that. And also there's water from oxidation, and that's just roughly 300 mils. So you get roughly 2,600 out, 2,600 in, and our body maintains that balance that we know of as homeostasis, right? We constantly are balancing everything in our body to get to that steady state or that continuous similar state. And that happens with fluid intake and fluid loss as well. So where is that fluid within our body? When we look at how we can divide the spaces that we find that fluid, 40% of our body weight is actually fluid that's within our cell. That's the intracellular fluid. So that's about 28 liters of fluid inside the cells. And remember, fluid can shift within the cell to outside of the cell, depending on a whole bunch of things that have impact on our fluid status and our electrolyte status in particular. But under optimal conditions, 40% of our body weight is intracellular, and that's 28 liters or so. And another 20% of our body weight, or 14 liters, is extracellular. So that's outside of the cells. And of that 14 liters, we divide that between intravascular, within the vasculature, right, within our bloodstream. We've got intravascular fluid, and we call that, another word for that is plasma. And then 75% of that, the remaining 75% of that 14 liters is interstitial, and that's just fluid that bathes our cells. So it's around our cells, within the human body, in other organisms. It's that interstitial fluid surrounds our cells and it bathes them. So what do we need to know? Just the bottom line about fluids. So typically, and I know you've all learned that, there's three sort of categorizations of fluids. Isotonic means it's the same tonicity, the same concentration of anions and cations, or typically of anions and cations, as the human blood or plasma. And so that an example would be normal saline, or 0.9% normal saline. Hypotonic means that there is less tonicity, right? Hypo, less. And an example there is half strength normal saline, 0.45 normal saline. Hypertonic solutions have a greater tonicity, greater concentration of solute, and that example there would be D5W in normal saline. Just to make a point that I'm going to make probably a couple more times. We typically work with isotonic solutions. Even if we think someone is slightly dehydrated or is in a little bit of fluid overload, we manage that in multiple ways. Moving to a hypotonic or a hypertonic solution is something that we have to watch very, very carefully. And so there are very good reasons why we would do it, and we'll talk about them in this course at different points. But it is most often that you, as a nurse working anywhere except in an ICU or a trauma setting, would see that you're using isotonic solutions, and what I'll call it essentially isotonic solutions. So some solutions might be slightly hypo or slightly hypertonic, but once the metabolism happens within the body at the level of the cellular metabolism, they become isotonic. So isotonic are the solutions that we're typically going to use. We want to see, to recognize the process of solute movement, right? And so what the impact of that movement is that as those solutes, and often those solutes would be like electrolytes, or they could actually be large protein molecules, albumin molecules, those solutes take with them fluid. So they move the fluid at the same time. And solute movement happens through two mechanisms. I'm not going to go into this in great detail because I know you've learned it, but just so you know, sometimes the diffusion happens. They move across those membranes, those capillary membranes, from areas of high concentration, or from areas high concentration to areas of low concentration to try to equal out that concentration, or they can move through active transport, right? So they can be moving in a good example is that sodium-potassium pump that exchanges sodium and potassium in intracellular and extracellular environments. And that fluid, again, can happen passively. So fluid will move along that osmotic gradient. So fluid will move to areas of greater concentration of solute, right? So the more you have dissolved in that fluid, the more likely you're to pull more fluid to that area. Or we can actually take part, there can be active processes to move fluid. Okay, so where is all this happening? Like, is it happening in all of my veins, between my veins and all the cells around them? No, it actually happens right at the level of the capillary. So it's a micro level cell where we have single cells of hemoglobin moving along within the plasma. That fluid movement within the vasculature happens right at that micro level, at the level of the capillary. And we call that, and it happens through a process that we call capillary filtration. And so it's those hydrostatic forces, the forces of pressure associated with solute and solvent, or the amount of solute in the liquid or a fluid in the fluid, and the amount of pressure that's being exerted forces fluids and solutes through those capillary walls, right? So that those mechanisms take place right at the level of the capillary, and the pressure forces those fluids and solutes through those capillary walls or brings them back. And one of those important molecules here is albumin. Albumin is a protein molecule, and albumin is quite a large, at the level of capillaries, quite a large molecule. And it's albumin that's traveling within the capillaries that promotes reabsorption. So it's albumin that pulls that fluid back to prevent too much fluid loss into the vascular. So we're not just seeping fluid out of our capillaries into all that surrounding tissue, but we've got albumin, which is too big to move out of the vasculature, and it pulls, because it's a big protein molecule, it pulls fluid back into the vasculature. So how do we keep a fluid balance? Boy, it sounds complicated already, and we've barely started. There's three main mechanisms. So just, again, we're hitting the high points here, three main mechanisms. At the level of our kidneys are intimately involved, and I know you all know this, and it's obvious, right? Because we excrete a lot of our fluid from our kidneys. So the mechanisms for compensation, where we either continue to excrete urine, make urine and excrete urine, or retain fluid at the level of the kidney, are really important, right? It makes perfect sense. So within our kidneys, we have what's called nephron tubules. And those either help us to retain or reabsorb water or excrete water, and associated electrolytes as needed. They also secrete something called renin. And renin is part of what's called the renin-angiotensin-aldosterone system. And I'm going to talk about that in a second. I don't like typically to go into these techie talks, where it feels like you're going to get lost in all the words and lose track of exactly what's happening. But there's a couple of systems here that I just really want you to know because they make sense. And as a high acuity nurse, you will have to understand them. So renin is secreted by the kidneys, those nephron tubules. And again, renin is going to be part of that renin, angiotensin, aldosterone system. And it's really the aldosterone, that end product, that regulates sodium and water reabsorption, right? So you want, when you are trying to prevent dehydration, or you're experiencing dehydration and trying to prevent further fluid loss, it's that aldosterone, that end product of that renin, angiotensin, aldosterone system that regulates your sodium level, and sodium is critical to reabsorbing water. Additionally, we have mechanisms through our hormones that moderate or modulate fluid loss. So antidiuretic hormone is produced by the hypothalamus. And you remember the hypothalamus is in our brain, right? So it's produced by the hypothalamus, excuse me, and that reduces diuresis. So it stops us from diuresing, and it makes us hold on to whatever water we have, makes us hold on to our fluids. And that's, again, we're part of this renin, angiotensin, aldosterone system. That's another hormone-based system. And then finally, we have ANP. And ANP is Atrial Natriuretic Peptide. I just call it ANP. And ANP stops that renin, angiotensin, aldosterone system, right? So let's say we've activated our renin, angiotensin, aldosterone system, so we're holding on to water, we're retaining water, but let's say we retain so much water, our blood pressure goes up high. We need something that stops that RAA system, and that is the ANP hormone. So we have got that balance. Remember, it's constantly that balance in those feedback loops. When one gets too high, the other one kicks in and brings it back down. Constantly those feedback loops to maintain homeostasis within our body. And then finally, that mechanism for thirst, where we're actually driven to have oral intake of extra fluid, and that's regulated in our brain as well through the hypothalamus. So within our kidneys, just a couple of notes. Glomerular filtration rate should be about 125 mils per minute. So our kidneys, within the glomerular, we have a filtration rate of 125 mils per minute, and that leads us to a urinary output, ideally, of about 60 mils per hour. Now, if our urinary output drops below 60 mils, do we call somebody? Do we notify somebody? Nope, because it's not 60 mils per hour every hour, and that's optimally. So we might have more sometimes than that, we might have less sometimes than that, but ideally we're looking for about that amount in a healthy, well-hydrated person. But the minimum required output is actually 20 mils per hour. And that's required to eliminate the amount of body waste that we have. So urine is necessary because we don't just pass water, but we actually eliminate waste. The way our feces or our stool eliminates byproducts of nutrition through our GI system, we also use our renal system to eliminate waste. So we need minimally 20 mils of urine per hour to eliminate necessary body waste, or they build up in our system, right? We end up with a buildup of waste. So do we wait until somebody has 20 mils per hour to seek assistance? We don't, because then we've reached a critical threshold. Remember, nurses always are vigilant in looking ahead. What is the next step? And activating mechanisms to prevent catastrophic events. So the standard alarm point, and I know you all know this, is 30 mils per hour. 30 mils per hour is half of the optimal level. Remember, we said the optimal level, or the normal level, 60 mils an hour. 30 mils is half of that level, but it is a threshold that is still significantly above the minimum amount, which is 20. So when you say 30, you're still in your minds. I'm not saying it's okay, but I'm saying the person, it is a warning sign. I'm going to pay attention to this. We need to take action, but I'm not critical yet. Okay. I'm going to talk about these systems just a tiny bit more, just so all of us are on the same page. So antidiuretic hormone makes sense. A diuretic makes us pass urine and get rid of excess body fluid. So antidiuretic hormone, what's it going to do? Help us to retain fluid. Produced in the brain by our hypothalamus. and it's stored and released in our pituitary gland. So our pituitary gland sort of in the middle of our brain there, and it's released by the posterior pituitary. And what that does is it restores our blood volume by decreasing the amount of diuresis. So it enables us to stop passing fluid and to hold on to fluid, so we have that water retention. And so what happens is when we have an increase in osmolality, so an increase in concentration of solutes, so electrolytes, albumin, other things, so the osmolality, the amount of solute to solvent, or decreased blood volume, so our body is able to determine that there's a decrease in blood volume. Let's say we've had a hemorrhage or we're profoundly dehydrated. That's going to stimulate the release from that anterior or posterior pituitary of antidiuretic hormone. And that antidiuretic hormone then circulates in our bloodstream, and it acts at the level of our kidney. And it causes our kidneys to kick into gear to reabsorb fluid. Instead of passing that fluid, those mechanisms are put into place to reabsorb fluid. And the result is that we actually pass much more concentrated urine. And that's what we would see with our eyes. When someone is passing urine that's very concentrated, their kidneys have kicked into gear to make that urine much more concentrated as their body reabsorbs that fluid. And when we have a decrease in osmolality, so when we have less solute in our bloodstream versus the amount of solvent, or when we have an increase in blood volume, right? So we have a lot of blood volume. Let's say we've got excess fluid on board, and our cardiac output seems quite large as we're trying to pump around that blood volume, but it may actually impede our ability eventually to have sufficient cardiac effect. ADH release has an opposite effect. So in that situation, we don't have it. It actually, when our body detects this decrease in osmolality or excess blood volume, so a high blood volume, then our body stops releasing that ADH. So our pituitary stops releasing that ADH. And when we have a decrease in that amount of ADH, we have less water reabsorption. So our kidneys are given the signal, go ahead, let that fluid go. And then we also have less concentrated urine. Our kidneys don't work to concentrate urine. I hope I did a fair enough job of that. Okay, the RAA system, renin, angiotensin, aldosterone. And it's just a cascade. This is classically how the human body works, all of these different mechanisms working in sequence. So let's say at the level of our kidney, blood flow to the glomerulus, right, that portion of our kidney drops. So blood flow drops, and our kidney responds by secreting renin. And there's certain cells, juxtaglomerular, I'm not going to ask you that, cells, and they secrete that renin. Renin is that then travels in our bloodstream to our liver. At the point of our liver, isn't it like they're working hand in glove, our kidney, then our liver. It converts that renin to another chemical called angiotensinogen. That renin converts angiotensinogen to angiotensin 1. So the renin goes to our liver. It creates a chemical response in our liver where angiotensinogen is converted to angiotensin 1. Now that angiotensin 1 is circulating in our bloodstream, and its target organ is the lungs. And at the level of our lungs, angiotensin 1 converts to angiotensin 2. So we've got this cascade. We started at our kidney, we went to our liver, now we've gone to our lung. And angiotensin 2 actually has the impact we're looking for. It causes vasoconstriction. And do you remember what vasoconstriction is? That's that tightening of your blood vessels. That angiotensin 2 continues to, it also circulates in our blood in a variety of ways, and it goes to our adrenal glands. Do you remember our adrenal glands are situated right above our kidneys, right? And that, at the level of our adrenal glands, it stimulates the production of aldosterone. And so do you remember the name of this? Renin, angiotensin, aldosterone. So renin was the beginning, secreted from our kidneys. It went to our liver. And at our liver, it converted a chemical there called angiotensinogen to angiotensin. That's the second name in our trio of terms. And then it went to our lungs. that angiotensin 1 converted to angiotensin 2 and caused vasoconstriction. The angiotensin 2 went to our adrenal glands, and at the level of our adrenal glands, it stimulated the production of yet another chemical, aldosterone, and aldosterone is the last term. Renin, angiotensin, aldosterone. And aldosterone, secreted by our adrenals, remember we're at the level of our adrenals, so our adrenal cortex secretes that aldosterone, and aldosterone regulates our reabsorption of sodium and water. Remember, sodium is so powerful in its association with water, holding water to it. It regulates our reabsorption of sodium and water at the level of our kidneys. Okay, I think we got it. My gosh, AMP, yet another system. Isn't the human body miraculous? So now we're talking about a system that's at the level of our heart, right? AMP, or atrial oh my gosh, am I going to get this wrong throughout this entire lecture? Let's try again. Atrial Natriuretic peptide. I bet Leslie would do a better job. That's stored in the cells in our atria, right? Remember we've got two atria, two ventricles in our heart. The atria are those two upper compartments, and that's where we have in the cells of those atria we have that AMP. When atrial pressure increases, so atrial pressure increases when our atria are filled. So as they are filled and they are with more blood, so more than usual amount of blood, and they are stretched, the pressure increases within the atria, and that is really the AMP is released. So when the atria get filled by as a signal that our body is pumping around so much blood that as it moves into our heart, the atria get so filled, the cells in our atria are stimulated to release that AMP. And what that AMP does, it's so perfect to have these counterbalances, right? So the AMP counteracts that system we were just talking about, the RAA. And so what happens is it decreases our blood pressure and it reduces our intravascular blood volume. So we want the RAA when we are dehydrated in particular. We want that system to be stimulated. When we are in fluid overload, we want the AMP process to be stimulated. And so how this one works is it's going to suppress those renin levels. So remember, we want it to counteract the RAA system. It suppresses those renin levels that are at the very beginning of that cascade. It decreases that aldosterone release. It increases the glomerular filtration rate. And so as that, remember we just talked about that a couple slides ago, that glomerular filtration rate is the rate at which our kidneys are filtering those wastes, and that increases our urine excretion and includes both water and sodium. When we increase that glomerular filtration rate, we excrete both more water and more sodium, and then it decreases that release of antidiuretic hormone from our pituitary. So this AMP counters that RAA system at all levels. And so ultimately that reduces that vascular resistance by causing vasodilation, all right? So we've got those, let's say those tight vessels, and it causes vasodilation. So you have, so there is not such a high perception of high volume. And so where it's possible, it causes vasodilation, so you're not moving through such a period of hypertension. We also manage fluids through a basic physiological process of thirst. And thirst results even when we have a very small fluid loss. We respond to that increased extracellular fluid osmolality, so we get a dry mucous membrane, dry mouth, and we tend to want then to drink. It stimulates the thirst center in the hypothalamus, so the hypothalamus has been quite central to this, right? And important to note when we see who in particular is at risk for dehydration caused by a non-traumatic or non-physiological cause just by not drinking enough, maybe elderly people, because we know as we age that mechanism for stimulating thirst is very ineffective. It can become very, very ineffective. Okay, what do we know about electrolytes? Now, again, just a basic review here. We've got anions and cations. And so anions are the negative electrolytes, so bicarb, chloride, phosphorus. Cations are calcium, magnesium, potassium, and sodium. And you see them in this picture down below, they balance each other. They balance by creating electroneutrality. So as they move in and out of the cell to create a net neutrality. And so typically what we have, or not all of them move in and out of the cell, but they variably do to create that net neutrality. So extracellular electrolytes typically would include sodium, chloride, calcium, and bicarb. And intracellular, we have potassium, phosphorus, and magnesium. You see there's also some calcium within the cell. Important to note that you see that potassium is within the cell. We want, and it's fairly large. That means relates to a large amount. Potassium levels in our body, when we would take a blood specimen and we would note it, it's important to recognize that our body responds to our plasma potassium levels, and that when our potassium, which is a critical electrolyte, we'll talk about it in a minute, level is too high, what we do is we give it a medication that will drive the potassium into the cell. So we can actually modulate or impact how much potassium leaks out of the cell or how much we can drive into the cell by understanding the mechanisms that underlie that. And that's just one example. But so recognizing that we want the net neutral between the positive electrolytes and the negative electrolytes within and outside of the cell. So what are our standard amounts? And I'm just going to say, don't get too hung up on this. Everywhere you work, there may be slight changes, tiny differences. You're going to work with the standard in the lab that drew the blood and provided the results. And some facilities go with different standards, and it's all fine. It's not that there's one single national standard that would be effective. But if you were ever to see a test, if you're writing a test, so for example, the NCLEX exam, they're not going to give you something, an electrolyte result that is one number off. So instead of saying sodium is 135 to 145 and your patient has a sodium of 146, that's not the kind of example you're going to get. But I am putting sort of rough common ranges here for you. So sodium 135 to 145, and again, we're using SI units, so milliequivalents per liter. Sodium is really powerful in affecting serum osmolality, right? So that the amount of extracellular outside of the cell fluid volume. And sodium is so powerful. What you always want to remember is that sodium draws water, right? It draws water to it. Sodium is really important for nerve and muscle cells and how they interact. And because of that, the impact of having a high sodium or low sodium is seen within the nervous system primarily, or at least as a priority, and then within other systems, and we'll talk about that later. Chloride, just again, don't get hung up on the exact number, but here's your rough number, 96 to 106 milliequivalents again per liter, and that helps to maintain your osmotic pressure, again, that pressure that helps to pull fluid one way or the other into a cell, outside of a cell. And really critical, so we know that chloride is really critical for our gastric mucosa, so for our GI system, or for our entire GI system within our stomach and even beyond, down through our intestines. Those cells need chloride to produce hydrochloric acid, right? Calcium, we know that we see that in our bones and our teeth. You often will see elderly patients where we're doing bone density scans and other things, and we're treating loss of bone density with calcium, either prophylactically or when we see that loss. Calcium has an impact on cell membrane permeability. So the ability of the cell membrane to open up to allow electrolytes to move in and out of the cell. So that permeability, whether that membrane and the openings in that membrane open up or are closed to allow that movement of electrolytes in and outside of the cell. Calcium is necessary for nerve impulses, and we see it's really critical in muscle contraction. So that sometimes the symptoms that we would see very first for high or low calcium levels would be around muscle contraction. So there's a couple that I'm going to talk to you about a little bit later. Also, calcium is essential for coagulation of blood. So really important that we watch for that. Sometimes where we'll see high calcium, low calcium is around our cancer patients. And then finally, bicarb. Bicarb is essential for acid-base balance. And we're going to have next week, I think, is your lecture on acid-base balance. So within the cell, we see potassium. Oh my gosh, potassium, you want to know it and never forget it. It's predominantly within the cell, but it's also found in the plasma. And so the normal plasma concentration of potassium, roughly 3.5 to 5 milliequivalents per liter. Sometimes you're going to see 3.2 up to 5. I've seen up to 5.4, but 5.4 is too high for me to feel comfortable. 3.5 to 5 gives me a rough benchmark. Anything above 5.2 seems really high to me, although again, you may work in a facility that has a slightly higher range. Some facilities have slightly lower range, so it might be 3.4 to 4.8. I'm just giving you a general range. Potassium is central to excitability of our cells, and in particular, a certain kind of cell, cardiac cells. That's where we're really going to see that. It's also involved in nerve impulse conduction and in muscle contraction as well. Phosphorus, critical for energy metabolism, bone and tooth mineralization, and again, acid-base balance. It has a lesser role, but it is still essential. Bicarb has a greater role, phosphorus has a less role, but still essential. Magnesium, it's a catalyst for the reactions that happen with enzymes. We see that magnesium is involved in neuromuscular contraction and promotes normal functioning of nervous and cardiovascular systems. Magnesium, it's an interesting one. So I'm going to give a couple of examples that you might think of, that we may give magnesium to people to help them relax when you think of neuromuscular contraction and the nervous system, to help people to physiologically feel less tension and be able to relax and sleep. And to have less nighttime movement, that sort of jerky nighttime movement sometimes. I think I'll just stop it there and not get too complicated with another example. Okay, so when we're looking at electrolyte imbalance, let's say I get my patient's electrolytes back, where do I go with this? Or let's say I see a funny sign, a sign that might be indicative of something. What would I do? So first of all, we always go to assessment, right? Face-to-face, head-to-toe, good assessment. And particularly, do you remember a couple of systems we've talked about? So nervous system, cardiac system, muscular, and so neuromuscular, always the tie between those, looking at fluid. So we want to do a full head-to-toe assessment, but doing a good cardiac, respiratory, neuromuscular assessment. We want to look at those lab results and understand not just what the lab results are today, but what is the pattern of those lab results, right? So are they a little bit hypokalemic, or they have a little bit of a low potassium, but it's on its way up? Or they were fine and now this is a sudden drop? It's important to look at the trend. That doesn't mean we wouldn't still report a concerning lab value, but we would look at it within the context of what is already known about the patient. And we also might look at the nursing, make a nursing diagnosis, consider whether a nursing diagnosis is relevant. In our program, we don't teach it. In Canadian nursing, it's so rarely used. I'm just going to skip over that for now. At this point, we would probably notify a physician, a nurse practitioner, or another member of the health team who might be critically involved in this situation. We're going to talk about what are the lab results. Hopefully, we would do an SBAR report. We talked about that when we had those case studies. Do an SBAR report and really look at the situation. So let's say I've got a high potassium background. Patient came in with acute on chronic renal failure and is scheduled for dialysis later today, but we're having a hard time securing a dialysis machine. The person's potassium came back at 7, I don't know, maybe that's too crazily high, 6.4. I don't know, then describe how they are. And my recommendation is that we prioritize dialysis, and do we want to consider some interventions to treat the high potassium before that can happen. And so then we'd look at what those interventions and treatments might be, and also what are the safety measures. So for example, in this situation where we have a patient with a high potassium, one of the critical safety measures is to make sure that patient's on a cardiac monitor, because potassium impacts the ability of those cardiac cells to function appropriately. We also would look at patient teaching. Is there essential patient teaching associated with this? And how does the patient respond to whatever interventions we might, or treatments that we might have enacted? Quick reference, a couple of things that come to mind. This is not everything, we're not making a diagnosis, but it's just worth sort of noticing, paying attention, having something that you sort of a point of reference for you. So when we look at electrolytes, let's say we're looking at our sodium level and we have an abnormal sodium level. What would cause a high sodium level? It might cause a low one. So a high sodium level is most often associated, I mean, there can be many causes, but most often associated with something called diabetes insipidus. And a low sodium level with SIADH, syndrome of inappropriate antidiuretic hormone. So you've got inappropriate antidiuretic hormone being released, and because of that, we have excretion of sodium in our urine, and we end up with a low serum sodium. Potassium, we tend to see high levels of potassium in two cases most commonly, but many other cases, but with burns, because we have that capillary membrane permeability, so that the membranes in our capillaries in the face of burns open wide, and we have potassium leaving the cells. We also have high potassium in the case of renal failure, when our kidneys are not able to function appropriately, where we see that as high potassium. Low potassium often associated with GI problems, sometimes with vomiting, even more with diarrhea. So watch for that. Chloride, high chloride is with hypernatremia. Remember, sodium and chloride are so bonded, they are so connected with each other. So often with hypernatremia, when we have a high sodium, we have a high chloride. And low chloride, often with prolonged vomiting. Remember, we talked about our stomach system, our GI system needs that chloride to make hydrochloric acid. And if we're vomiting excessively, we're vomiting that out. So we may have a low chloride. Calcium, high chloride is a really interesting thing that we see with hyperparathyroidism. I'm not going to go into it in detail, but it's your parathyroid gland can start overfunctioning, and in its process of overfunctioning, you see a high calcium. And a low calcium often associated with pancreatitis. Pancreatitis is interesting, fascinating inflammatory process associated with our pancreas, and it actually has a very high mortality rate. So it's a critical illness. Pancreatitis is not something to be treated lightly, and patients with pancreatitis are always admitted to the hospital for observation. Phosphorus, high levels typically with renal insufficiency. So when our kidneys are not working appropriately, we see high phosphorus, and low when we have diabetic ketoacidosis. So in that process of buffering, remember I said that bicarb and phosphorus are associated with buffering, or with your acid-base balance. In that process of buffering, when we have diabetic ketoacidosis and we are acidotic, then we see, we use up our phosphorus, we end up with a low phosphorus level. Magnesium, again, high in the case of renal failure. So in situations of patients who are in renal failure, they tend to have a high magnesium. And low magnesium most often caused by malnutrition. So we watch for that we may watch for that in children and also in the elderly. So we keep a close eye on that. Okay, now managing fluid status is really critical when we consider IV fluids and understanding the two broad categorizations, and within them, what do we see? So I think I don't know why when I was first introduced to these when I was a nursing student, they seemed like foreign ideas because now they seem so obvious. Crystalloids are IV fluids that are made up of molecules, so they're not either natural or synthetic human molecules. Molecules are made up of human protein and other things. They are those like electrolytes or those molecules that we've been talking about that can flow easily within our bloodstream into our cells and into our tissue. And so there's three kinds of fluids that are crystalloids. Almost always we are working with crystalloids. Colloids are used less often, but often for critical reasons. So isotonic fluids, remember we talked about that, normal saline is an isotonic fluid. Isotonic fluids have little net fluid shift, right? So it's the same concentration, the same tonicity as our bloodstream, as our blood. Hypotonic fluids, that causes, because the fluid has less tonicity, then fluid moves into the cells and the cells swell. And so that would be, an example would be half strength normal saline, 0.45 normal saline. So hypotonic causes the fluids, the cells to swell. And hypertonic solutions pull fluid into the bloodstream. So they pull fluid out of the cells into the bloodstream. And a couple of examples that you might see, D50. Now, we don't usually give D50. Sometimes we do, or you can give much D50, but we don't usually give it just running in an infusion. But an area of real interest lately is the use of hypertonic fluids for trauma patients. So instead of giving somebody, you're giving them packed red blood cells and you're giving them normal saline, instead of giving, let's say, an acute trauma, 10 liters, 12 liters, 14 liters of normal saline or Ringer's lactate, where it's a hydrating solution. It's an isotonic solution, but it's hydrating. You're giving lots of volume because somebody's in shock. They have no blood pressure. You're trying to bring up their blood pressure. One of the things we might do is give 3% normal saline, where that's actually leveraging the amount of fluid our body has by pulling fluid from those spaces that we don't necessarily need, and pulling fluid into the vasculature, right? So into the bloodstream. So we'll see that there's a lot of emerging evidence around this. Sometimes it's still a little dicey around that evidence, but it's important to recognize, and particularly if you're going to work in trauma, you're going to see the use of hypertonic fluids now a real area of investigation. So that's the crystalloids. Those are the things that we're used to. It's the normal saline, 2/3 and 1/3, Ringer's lactate, D5W, D5 normal saline, half normal saline, half normal saline, 2.5 D5, or dextrose. It's the combination of sodium and dextrose and potentially other solutes. So for example, in Ringer's lactate, we've got some other solutes that create a level of tonicity that's the same as our blood. Hypotonic, decreased tonicity; hypertonic, increased tonicity. So hypertonic solutions pull fluid out of the cells. Hypotonic solutions make the cells swell up. Then we have those what are called colloids. Colloids are always hypertonic. And what do hypertonic things do? Hypertonic are volume expanders, right? We increase volume in the vasculature, right? And so the kinds of fluids that are hypertonic colloids are things like albumin, and albumin comes in 2 strengths. So, and have you ever seen albumin? It's in those bottles, right? It's kind of a yellowy browny color, clear, and it's in those bottles, and we transfuse it from those bottles, or other kind of volume expanders like dextran. And sometimes colloids are controversially used when we're talking about, managing acute fluid issues, so acute hypotension or something. But situation specific, they can be really important. I'm not going to go into detail, but in particular when we have patients with acute ascites, a process where we have protein molecules that have crossed over into the peritoneum, and they're pulling with them fluid, and we may tap a patient, and as we tap that ascites from a patient, we are removing not only fluid but those protein molecules. We may then need to use albumin to restore fluid balance within the person's body, and the risk if we give them fluid, for example, normal saline or something else, is that all that salt is going to cause that movement of whatever albumin they have within their natural system, that protein, across that membrane as well. So they actually make the problem worse. So there are very specific situations in which we would use those colloids. And again, you're going to pay attention to your clinical area. The example I gave you around ascites would be an hepatobiliary kind of medicine. And you may see that in the ER as well, and TAPS in ICU. You may see plasma expanders in trauma situations. These effects, the challenge with colloids is that the effects don't just happen immediately. So when we give normal saline, our effect is immediate. We see our effect. But with colloids, it's very complex, that it can take longer for that effect to happen, and it can last for a very long time. So even if we're giving a colloid for a very specific reason, and it's warranted, we still are going to watch for signs and symptoms of hypervolemia, so excess fluid, holding on to excess fluid, because they are always hypertonic, they're always plasma expanders. And so when you think about when we give a patient a blood transfusion, we're always watching for fluid overload. When we give a patient albumin, we're always watching for fluid overload. When we're giving a patient dextran, it's because they're critically hypovolemic. Okay, so I want to just talk about some of the most common fluids you're going to see, right? There's 4 that I'm listing here, and I'm just going to give you like sort of the down and dirty on this for me. So let's start with D5W. D5W is considered a maintenance solution, right? Just maintenance. We typically are going to see it in a TKVO kind of rate. If you've got a patient getting D5W at 125 mils an hour, it's the wrong solution. It's a maintenance solution. It is not a volume replacer. It's just maintenance, typically a TKVO, maybe up to 75 an hour. Even then, I would be questioning it. So typically, it is a TKVO rate. We may use it when we have hypernatremia. That's the thing we have to be cautious of. We may use it when we have hypernatremia or when we have very mild dehydration. The other patient we're going to use it for, and again, I don't want to talk too much about the one-offs, is that patient we talked about a little bit before with the ascites. When a patient may not be able to tolerate. There's very rare situations where D5W has a use in fluid resuscitation, but they are so unusual that it really, you have to know your craft and understand why that might be. Typically, only maintenance. We would watch it with renal disease. We also are going to watch it with cardiac disease, although keeping in mind that the most common solution that we're going to see with a cardiac patient might be a D5W TKVO, or hopefully if the patient doesn't need fluid infusing, then we would switch them over to a lock. Let's see, if a patient is at risk for fluid overload, we often are using D5W. So just to keep that in mind. So normal saline, do you remember we talked about that? Isotonic. An isotonic solution that is most often used for fluid replacement. So fluid volume replacement, isotonic solution, we want the same tonicity as our blood, and we want to be able to infuse that, transfuse that, or infuse that fluid. And the kinds of things that we would use that for would be shock. We have to give it, of course, with blood transfusions. If a patient was hyponatremic, they don't have enough sodium, then we would be giving sodium chloride in their IV. For something like a diabetic ketoacidosis, it's important on two levels. It's important because of the sodium, and it's important because a person in diabetic ketoacidosis, by nature of that disease process, is profoundly dehydrated. So it's a member fluid volume replacement. It's a hydrating solution, right? And we also use it for resuscitation. So in a cardiac arrest or a resuscitation when somebody is profoundly hypovolemic, we would use a normal saline as an excellent first choice. So you're thinking D5W, maintenance. It's not for hydration. It's not for somebody who's dehydrated unless it's special cases. But it's a very effective maintenance solution. Normal saline, on the other hand, which is also isotonic, is an excellent fluid replacement solution, right? Excellent fluid replacement. We would watch the use of that solution in patients with heart failure. If you've already got edema and we give you normal saline, you're going to have much more edema. That sodium, remember, holds water to it. Or if you've already got a high sodium, we're not going to give you a solution of normal saline. And again, with normal saline, because sodium holds water to it, we're going to watch for fluid volume overload. Lactated ringers or ringers lactate, you can call it either way. We typically are going to see those used in with surgery, pre-op, post-op, with burns, and it's really critical that we use those formulas with patients with burns, and the fluid that we're typically using is ringers, and with GI loss, often replacing GI loss with ringers lactate. When we have acute blood loss, we can use ringers. And when we have third space losses, so that's when we have fluid losses, but it's not a loss from our body, but we're losing, we're bleeding, we're third spacing. We're third spacing fluid into our peritoneal cavity, into our, joint cavities, into our, we're profoundly edematous. Post surgery, where we had many liters of fluid, and we're waiting for that fluid to come back out, to come back into the vasculature. We typically are giving ringers. Now, the consideration thing to keep in mind when you're using ringers is that it has electrolytes in it, and that's why it's important for surgery. It has electrolytes in it, and they're similar to our serum, except there's no magnesium. And because it contains potassium, the patients that we're going to really watch in giving that would be renal patients, right? They can't tolerate any extra potassium. The other thing is that it's really critical when we have patients who are in liver failure and they have a problem with lactate, that we don't want to give them ringers lactate, because that's going to be a problem for them. And then finally, another very, very common IV solution, 2/3 and a third, 3.3% dextrose and 0.3% normal saline. So do you notice how beautiful that is? 2/3, 2 3s, 3 3, and 1/3, 1 3. So 3.3% dextrose, 0.3% normal saline, and it has a little bit of both. So it's good for some maintenance functions, and it's also good for some hydration functions. So 2/3 and a third is the kind of solution you're going to see running at 75 an hour up to 100, sometimes even 125. If somebody's in shock and they need IVs running wide open and a fluid resuscitation, we're going to use one of the hydrating solutions. Those are the two above, normal saline and renal lactate. 2/3 and a third is a mix of hydrating, a little bit of hydrating, and a little bit of maintenance. And you remember the maintenance solution was the top one, the D5, right? And often 2/3 and a third, we use potassium as an additive. And remember, if you've got potassium as an additive, you immediately want to put that to a pump. The balance of 2/3 and a third is that it's got some dextrose in it, and that dextrose is not enough if you've got a low blood sugar. It just is enough for cellular metabolism. And if you don't need any hydration with it, you go to the D5, which again is just enough sugar for cellular metabolism. Some people overthink whether a diabetic patient can have D5 or even 2/3 and a third. It's just enough for cellular metabolism. So unless you're giving a lot of IV fluid, in which case it's probably not the right fluid anyways, you wouldn't worry about that little bit of dextrose. It's just enough for your cells to continue the required activities. You often give 2/3 and a third to patients who are NPO when they have just a little bit of dehydration. So a mild, even to a moderate dehydration, you might give 2/3 and a third. Post-operative, once you come out of the OR, you probably had Ringer's lactate pre-op and in the OR. Post-op, often then we move once you're beyond that phase to 2/3 and a third. Typically, again, the rate dependent on whether you're eating or drinking and for how long a period of time you will not have oral fluids, and also how we are assessing your vital signs and your fluid status. Important, this is just like so down and dirty, reference for IV rates. So maintenance. So this is not somebody who's dehydrated. We are putting an IV in, and it's sort of a TKVO rate. TKVO rate, hospitals are going to have policies. Get used to looking up the policy. That's going to be very site by site, 25 to 50 cc's an hour. For a TKVO rate, you can use a pump, you can use a Buretrol, or a micro drip tubing. If you've got a macro drip tubing, it's too easy to let that will get ahead of you. So micro drip has that little tiny metal drop. A Buretrol we often use in pediatric patients. If you haven't seen a Buretrol, let me know and I'll bring one to class. Or just hang it on a pump. Almost everybody has their IVs running on pumps now anyways. Sometimes we use it when we're keeping a line open for meds. And if we're giving meds less often than every 4 hours, so it's more that if it's a greater time period than 4 hours between meds, routinely, not just once in a 24-hour period, but within all the IV meds that we're giving over the course of a day, and the person doesn't need fluid for any other reason, consider moving to a normal saline, much more effective than running fluid that we don't need. We also tend to use a slower rate of fluid with cardiac patients. We really want to watch that they don't go into fluid overload. And as surgical patients move beyond their surgery and their diet is progressed, we might watch for having a maintenance rate, 25 to 50 mils an hour for a day or so, just as we're about to discontinue the IV, just to make sure that they're eating and drinking effectively. When we're looking at a patient who's got a mild hydration requirement, right? So you're a little bit dehydrated, not profoundly dehydrated, not in shock, but mild to moderate dehydration or hydration need. All things being equal, we're going to talk about this. So there's a lot of specifics that go into everything, but these are just sort of general rule of thumb, keeping it in mind. You're typically going to look at 2/3 and a third or normal saline. Watch cardiac patients. Remember, we talked about cardiac patients can easily go into fluid overload. That sodium holds water. That water is going to put a patient into fluid overload if that heart is not able to pump effectively, right? So watch our cardiac patients. But so for mild hydration, the rate we're looking at is roughly 75-ish an hour, okay? So this is I'm just giving you some ballparks, right? Roughly 75 cc's an hour. We're going to watch body weight. We're going to watch whether the patient is taking any PO fluids. If the patient is completely MPO, 75 cc's an hour is inadequate. So that's not enough. But so for some mild hydration on top of PO intake, roughly 75 cc's an hour, And again, this idea is patients, post-op patients are starting to eat again and beginning to take PO, then we may be looking at that hydrating rate of about roughly 75 cc's an hour. And the solutions for that would be 2/3 and 1/3 or normal saline. Watch that if you are trying to get somebody to eat or drink and you continue to give them exogenous fluids, we keep running that IV, they may not develop that thirst. So you just want to watch that, and also watch for older patients going into fluid overload. And then finally, a hydrating solution. So we had a maintenance solution, we had mild hydrating, and now we're going to real hydration. So this is a person who may be MPO, who may have a low blood pressure, who may be hypovolemic in some way. We are going to use a hydrating solution. Hydrating solutions are 2/3 and 1/3 normal saline and ringers. 2/3 and 1/3, remember, is a little bit hydrating and a little bit of that maintenance, has a little bit of sugar. So if a patient is profoundly dehydrated or profoundly hypotensive, we're not going to use 2/3 and 1/3, we're going to use one of the other two, normal saline or ringers, but all three of those solutions have some real potential for hydrating support. The rate when we need to hydrate a patient is going to be somewhere between 100 and 125 an hour. We can go up to 150 an hour, but we're going to really watch cardiac status. We're going to look at the age of our patient and whether they're taking anything in by mouth, what their output is, making sure they don't go into fluid overload. Typically, we see 100 to 125 an hour. And then also we've got bolus rates, and that's going to depend on a whole bunch of things: cardiac status, level of dehydration. If the patient is acutely ill, for example, in shock, then we're talking about something entirely different. But for the patients that we would see in a regular day, on a regular unit that we're paying attention to, and we're providing with fluid through IV mechanisms, we're categorizing them along those three requirements. One is a maintenance line. That's going to be 25 to 50, typically D5, but we're going to watch specific patients. Mild hydration needs. That's a patient who's taking something in PO by mouth. They're taking some fluid in by mouth. Typically, for mild hydration requirements, we're going to use one of two solutions, either 2/3 and 1/3 or normal saline. Watch cardiac patients with normal saline. And then if we need a fully hydrating solution, or a situation where a patient needs full hydration, that would be a patient who's typically MPO or is dehydrated or behind on their fluids or other kinds of things, but they need hydration. We're looking at three solutions: 2/3 and 1/3, normal saline, ringers, lactate. The least effective of those at full hydration is 2/3 and 1/3, because remember, it's split between some hydrating properties and some maintenance properties with its glucose. So it's an effective post-op solution. It's an effective solution for a very stable patient as we're giving them fluid if they're MPO, something like that. Otherwise, if we need full-on hydration, a bolus, a patient who's hypovolemic, other kinds of things, we're looking at normal saline or ringers lactate. Hydrating rate is about 100 to 125 an hour. It may go up to 150. You're going to be very cautious about that and really determine if that's appropriate. And then there's also bolus. And that's it. Wow, can you believe it? I said it was going to be 20 minutes, and I know it was not 20 minutes. So I apologize for that. But on we go. I'm going to record another lecture that is a little bit more specific for you around some specific electrolyte impacts. But for now, that's it. And it was a pleasure, and I'm going to post this as soon as I can. I hope you all stay safe and warm. It's incredibly slippery outside. So take care of yourselves, and I will see you next week. Bye.